for prolonged period, which will not come in contact with the vessels for long period. So these are the semi-critical. And also non-critical, this is the device which which is uses only on the intact skin only. So this critical condition will require the sterilization, where the all visible microorganism must be destroyed. The semi-critical, the conditions where the which implants which are used, which should be treated with a high level of disinfection, where the all viable microorganism must be destroyed except the bacterial spore, whereas the instrument which is used for the non-critical condition, that it requires a low level disinfection, the most vegetative bacteria and the viruses should be destroyed except the bacterial spores, mycobacteria, fungi, and the small non-lipid viruses. So sterilization is complete destruction or the removal of the all viable microorganism, which includes the spores and the viruses from instruments and the equipments. There are several methods like physical and the chemical. Physical means the dry heat or the moist heat, and the chemical. Physical, first of all, you have the dry heat sterilization. The intentionally, I'm skipping this slide because the basic orthopedic instrument should not be sterilized by dry heat. Basically, we have to use the autoclave, that is a moist heat. There are three ways of autoclaving. Standard autoclaving should require the 15 pounds per square inch pressure. There's a temperature at 121 degrees centigrade, and time is 15 minutes. There are several other procedures, like this is the standard technique, but other techniques means the 20 pressure, 126 or 134 degree temperature, but the time limit should be reduced for up to 3 minutes. But this is not the standardized. Standardized is the 15, 121, and the 15 minutes. There are different types of autoclave which is asked in the examination. That is a downward displacement autoclave, positive pressure, negative pressure, whereas a triple vacuum autoclave. So basically, these are effective against the vegetative bacteria, including the tuberculosis, viruses, hepatitis B virus, C virus, heat-resistant spores like Clostridium tetani and Clostridium perfringens. Medical instruments should be unwrapped during the autoclaving. Metal and the trays should be wrapped. Rubber gloves, dry, powdered, individually packed in linen that should be covered with the clothes, and threads like linen, skin, nylons, metal wares, linen, towels, gowns, dressing should be easily sterilized. Now, flash sterilization. This is only to process the critical surgical item in an emergency situation. This is not a standard type of autoclave, standard type of sterilization, never to be used for the implantable items or to compensate for storage of the key instruments. Basically, it is 132 degrees centigrade for 3 minutes, and it is pressure is 27 to 28, that is pound per square inch. So the gravity displacement sterilization, the flash sterilization should be only be used for very emergency and critical condition. This is not a standard way of the sterilization. Another method is ethylene oxide gas sterilization. Is highly penetrative gas, and basically it is a way of filtration that can sterilize this instrument, and is active against the bacteria, spores, and the viruses. It has irritating, mutagenic, and the carcinogenic effect. Instruments sterilized by ethylene oxide should ideally be stored for a minimum of 6 hours before use. It is a limited availability and the high cost. Basically, what are the other structures which can be, apart from the implants, which can be used for sterilization is the heat-sensitive equipments like the heart-lung machine, respirators, sutures, implants, and clothing and bedding. Now, another important quick sterilization is the Sidex. It's very popular among the orthopedic surgeons, and basically it is a 2% glutaraldehyde, and basically it should be kept. It should be the instrument should be immersed inside this liquid for at least 10 to 30 minutes. It should be minimum 10 minutes. This ideal should be 30 minutes. Basically, all the scopes, the like arthroscopes, endoscopes should be sterilized in this method. There's no deleterious effect on the semen. New generation Sidex activated GTA, providing the superior rate of biocidal action against all microbes, including the Mycobacterium tuberculosis. Another way of sterilization is the gamma sterilization that can be pre-sterilized. That the instruments or basically the implants basically just pre-sterilized by gamma sterilization that kills the bacteria by breaking down the bacterial DNA, inhibiting the bacterial division. It is used in plastic syringe, hypodermic needles, scalpels, surgical blades, adhesive dressing, and the implants. Now, how to wrap the instruments during this sterilization? This is very important, and that can be asked in the DNB examination. That should be, the wrapping should be done in a square wrap with a 6-inch border around each other like a pan. If cloth is used, it should be used in 3 layers. It is most important. but it should be penetrable. The steam should be penetrable through this any type of wrap. Alternative wrap is 140 thread count per inch. Any cloth which has a 140 thread per count per inch, that can be used. Basically, the 100% cotton muslin can be used for this wrapping. Another important, how to monitor whether it is properly autoclaved or not. So there are two types. There's autoclave tape. You can see here this type of tape. This is before autoclaving, and just after autoclaving, what is happening? You will see these strips become completely change its color. It's almost blackened like this. This is done. This is the 5th October. Another important is a chemical indicator. It's an internal indicator. Again, it can be used for this when there is change color. So indicator should be checked prior to using any item. If there is no color change, should not be used. Now, there are some specific criteria to know whether the autoclave is normally functioning or not. So, what are this method? This is sometimes asked in the examination. Suppose the hot air oven that can be tested if the Bacillus subtilis, especially the Niger Clostridium tetani, is persist after injecting at the area after using this auto air oven, it is not working. So it should not be alive. Now, for the autoclave, we have to see whether the Bacillus stearothermoplast should be died or not. Now, another is filtration method like DTO. You have to see the Serratia marcescens and the Pseudomonas diminuta, which should be this is used for the making its effectiveness. And there is the ionizing radiation, the gamma radiation. It can be the Bacillus pumulis, which is used for its estimation of the effectiveness. Now, what are the normally questions asked in the MS or orthopedic examination or the DNB orthopedic examination regarding the instruments or the implants? Now, basically, there are two types of instruments. It may be general instruments or the special instrument. General it may be general surgical instrument or general orthopedic instruments. Basically, these are the questions generally asked by all the examiners. Like first, you have to identify the instrument by its name, preferably the name of the inventor. Next is the parts and the function. Then the use. It may be general use and the special use. Lastly, the limitation and the disadvantages and sterilization method, and whether it can be modified form is available in the market, and what is this modified form is its functions. Now, it is special instrument. We have to identify at least the name and the first and special use in which part of the surgery that special instrument is used. This is sufficient. These are the basics. Now, this is the Spencer's Wells hemostatic person. How to identify? This is that at least 1:2. So this blade portion is a one. If you consider one, this is the handle portion should be its double length, and it's a single lever. It may be straight or curved. There's a several. It is easily, and there's this clamp is there. Now, the use is a suturing, holding bleeding vessels, holding knots. Special use, making the passage of the percutaneous insertion of the sun screw, Steinman pin, interlocking screws, and especially for the pediatric use during the caver fixation, especially if you use the medial caver fixation, cross caver, the medial caver fixation from the medial side, just after knee caver, the skin incision, we have to introduce this vertex forceps or the mosquito forceps. So we have to make its passage. Now, what are the types of these articular forceps? It may be small, that is the mosquito, which is not the Halstead forceps. Medium is a Spencer Well forceps. Large or articular forceps, it can be called, which is a Bailey forceps. Working, how to know it is working or not? Now, try to holding your body here. If it can hold the body here, that means it is working well. Okay. Now, this is Chittle's sterilizer forceps, which is no lock. These curved blades used to pick sterilized instruments direct from the boilers and formalin chambers to avoid the touching. Now, how will you use? This is the questions asked. So basically, before using this, we have to wash our hands by a proper technique. Then we have to wear the gloves, sterile gloves. Then again, we have to hold it. This should be autoclaved for this purpose. Otherwise, how it after first use, we can put it on a fresh Savdon solution. Why fresh? Because if you keep for a long time, Pseudomonas can grow in the Savdon. So it is asked in the examination. Another is a solution of methylated spirit can be used for its preservation. For this first use, you can use this, and then for the repeated use, for the after some time use, we have to discard it. Now, this is a sponge holding forceps. This is used to hold the gauze or mops during the preparation of the surgical site. Now, what are the sequence of antiseptic draping? Why the betadine is used at the last part during orthopedic? These are the questions asked. Now these are the jaws with transverse serrated ends. It has a lock in the handle. So the cocker is a Rochester Osner forceps. Basically, it is a cocker forceps or Rochester Osner forceps. It can be straight or the curve. Basically, in its tip, it is a one side is a one teeth, another side is a two teeth. So it is a closed clasp at the tip. Now used to hold the tissues with during surgery. With these tough tissues during the surgery. And the holding the meniscus during the meniscectomy and the total knee arthroplasty, retrieving the bone and the soft tissue fragments after its cutting. Now, special use. Suppose it is asked in the examination, is opening of the femoral medullary canal before use of the canal finder during the hemiarthroplasty. Because if you use the canal finder, that may cause the false passage in a very osteoporotic bones. This is the blunt tip, so that will not complication can be avoided. Now, this is Alice tissue forceps. Basically, it is described by Thomas, and it is a sharp teeth, the multiple teeth, very sharp, it's curved, and basically it is used usually hold or grasp the heavy soft tissues like the deep fascia or the skin flaps for the purpose of the retraction. Now can be used temporarily hold the thin bones. Then this is a special use, like the radius ulna. This is a temporarily acts as a reduction forceps for the radius ulna. Now this is the Lahaye's right angle forceps. You can see here the serrations of the tip used to pass the ligatures and the nerves and tendons, can be used to pass the sutures across the bony tunnels like muscle pedicle bone grafting or the nice knot. This is specific knot which is used for suturing the comminuted clavicle fracture. Now this is a pointed reduction forceps. Now available in the small and large size used to hold the bones to achieve the reduction, the olecranon and the medial malleoli. It can be used for temporarily achieving the compression in the tension when wearing sutures in the olecranon patella. Usually comes with a lock with the self-holding forceps. Now, how do I identify this? How do I differentiate this from the towel clamp? Towel clamp. This is the Backer's towel clamp. Basically, the span of the towel clamp, there's a space between these two blade is not much in the towel clamp, whereas the reduction forceps there is which is widely separated. So this is the mainly only way. Another is the clamp. This is specifically clamp is more than 3 or 4 clamps is usually seen in that. As you can see here, the multiple clamp. This clamp portion is very large, So we have to hold a very wider hold, but the clamp portion is very small. So this is basically it's a towel clamp, as it can be used to in place of the pointed reduction forceps. It has a smaller working area compared to the pointed reduction, as I mentioned. A temporary roller gauge can be used to tie while reduction. Now, this is a bird Parker handle. This is basically used available in two forms. This is a size 3 and size 4, to holding the specific fits of different types of blades. How to attach the blades? This is asked in the examination. Not with the hand. We have to use the ideal artery forceps on any instruments during this attaching the blade with this handle. This is most important. Now there are dissecting scissors. There are two types of dissecting scissors. It is a Mayo and is the mesoworm scissors. This is the Mayo scissors and the mesoworm is a gradual tapering end. You can see here, this basically is a gradual, slender, gradual tapering end. Whether it is the abrupt end, the tip is blunt. If it is a straight one, that can be used in the surface. If it is a curved one, that can be used in the deeper tissues to dissect the nerves and the arteries. Now the Mayo Hager needle holder. This is most important. You can see here is very useful instrument. It's a groove. It is a crisscross groove, crisscross serration, along with a small indentation inside its blade to hold the needle firmly. It is the length of the blade is equal to the length of the box joint. Used to pass a needle holding the suture through the tissues, but the special use is holding or bending or projected end of the K-wire during the tension band varying to bending the K-wire or to hold the K-wire during its this hammering, during this punching of the last part after its bending. This is a general retractor. How to identify? These are the Langenbeck, this is the Arminavi, and this is the cat's paw, the Volkmann's retractor. This is the Langenbeck is a single retracting blade, whereas the Arminavi retractor, you can see here, this is asymmetrical retracting blades. Whereas the Volkmann's retractor is a prone retracting blades with a multiple teeth. You can see multiple teeth. This is a cat's paw or Volkmann's retractor. This is a Homan's retractor. You can see here is a handheld lever used to pull the soft tissues away from the bones during operation, so that the neurovascular damage will become prevented. It can come in varying size depending on the size of the bone and can be straight, curved, 90-degree, the right angle. It can be sharp or blunt like that. This is a Farabu periosteum elevator. It is a very, very, it is how much thick it is. If it is very slender, that can be called as a Mitchell, whereas the blade is little bit longer. This is the thumb rest for providing the pressure for effective the effective elevation of the periosteum, and this is the handle you can see here. This is the very slender periosteum elevator without the thumb rest, which is used for the slender bones like the radius and ulna. Now, other periosteum elevator, this is the key periosteum. It is a metal handle, specially used with very small blade with maybe straight or curved. It can be used for the spinal instrumentation. There's no thumb rest. This is the key periosteum. It is a AO type periosteum elevator with a wooden handle. The Bristow's elevator or the retractor, it also calls the bone lever. It is a curved tip with a small long handle. It can use to retract the soft tissues away from the bone, which can be used for delivering the head during the replacement of the femoral. This is a special use. Removal of the fractured femur, this pair of the instruments, and can be used to create the passage for passing the plate during the minimally invasive. There is a MIPO technique. Also, you use the pass the plate, just making a small incision over here and small incision below. We can pass this to make a tunnel even above the periosteum to maintain the periosteum, so that the extra periosteal placement of the docking plate can be used. Now there are different types. I'm not going into details. The lens periosteum. This is a straight blade. This is a curved blade with serrations, and this is a lever for the radius. And I already showed. The dural retractor will come for the spinal injury. Now this is small, medium, large bone hook to retract the bones, like the cutting after cutting the femoral head. When we try to make the acetabulum cavity in THR, we have to remove the cut the trochanteric cut femur from the field of the acetabulum with the help of this bone hook. And there is the Bristow's periosteum elevator. It is same like the Bristow's lever, the bone lever, but this end is very sharp and it is little bit bent at 90 degree, so that it can serve the both purpose to as a bone lever or to elevate the periosteum. This is the Jones periosteum elevator. It's very slender. This is curved blade. It can be used for the elevation of the periosteum. This is the bone curate or the Volkmann scoop. This is the Volkmann scoop. There are under Volkmann, there are several instruments which is asked in the examination. Volkmann's scoop and the Volkmann's retractor. Now this is nerve root retractor. You can see I will come in the spinal instruments. This is the Homann's retractor, skin hook. This is the one slender Volkmann's retractor. This is Mitchell. I already shown. This is almost a parabolic type, but it is very slender with a longer blade. This is a Chandler's retractor used for the total elbow. This is a right angle retractor. Now bone chisel. This is a bone chisel cutting instrument. Come to the cutting instruments. The parts is a striking surface. It is the sharp and it is the blade. Shaft of the handle and the blade. So basically, it's a striking surface. It's only one end of the blade is beveled. If you see the curtain, one side is beveled. It's a mono bevel. One side is straight, another side is beveled. Is used to chip the bone or the bony growths or the osteochondroma or the bony tumor for the extra periosteal resection. This is the basically primary use. Special use, taking the bone grafts of different thickness by using this beveled end towards the bone or away from the bone. There are different types of bone grafts can be taken. Now osteotomy, this is basically it's a special instrument. Basically it is for the osteotomy. Now it is asked what is the difference between osteotomy and osteoclasis. Basically the parts are, again there are three parts. One is the striking surface. This is the sharp. It may be smooth or it may be rounded or it may be faceted. See, in this case it is faceted. And this is the blade. It may be bibeveled. You can see that both side is beveled. So basically it is used for the osteotomy. Now what are the osteotomy? What are the different types of osteotomy they ask? Now blade may be straight, may be curved, as you can see here. Lambert osteotomy. It is basically like a scale. It's a very thin osteotomy. Basically for the fine, for cutting the fine bones, you can use this. This is the Smith-Patterson heavy-duty osteotomy. You can see here for the striking surface, and the shaft is so strong enough, and the blade is maybe it's very stout. So this is a Smith-Patterson osteotomy. Now this is a styly osteotomy. You can see it's a delicate osteotomy with a cross-serrated hand, and the faceted the shaft. As in this basically it is a styly osteotomy. And this is a mini Lambert osteotomy. It is not used in the orthopedics, but also it is used for the jaw surgery or in the plastic surgery. Now bone gouge. It has a handle. So you can see here again it is striking surface. It is a sharp. It is usually square shaped. Very rarely it is rounded or faceted. Basically it is square shaped, sharp, and this is the blade. Now this blade is a hollow chisel type, hollow chisel with a very sharp end. It can be used to contour the bones, to harvest the bone graft for saucerization and the curettage, and clean out the medullary canals, remove the cement, and remove the broken bones. Now this is a bone awl. What is the awl and what is the brad awl? Awl should not have the holes. The brad awl should have the holes. This is the basic difference. It can be straight, it can be curved. This is basically is used to create a tunnel through the bone for the passage of the suture to the eye, like as it is used attaching the rotators to posterior aspect of the trochanter after hemiarthroplasty, that is insertion of the prosthesis is over. There is the reinsertion of the short rotators at the posterior aspect can be done with this with the help of this Lohmann's bone clamp. It can come in small and the large sizes. It's used to hold the reduction with or without the plate across the fracture sites. It has a threaded self-locking mechanism. You can see here threaded self-locking mechanism. Now, bone holding forceps come in different sizes. It can be self-locking or the non-locking. It can be tooth. You can see these are the tooth or the non-tooth. It's a non-tooth. This is self-centering bone holding forceps. It is used to hold the bone to aid in reduction during the fracture fixation. This is a Farabut-Lambert type. This is self-centering bone type. This is a Ferguson. This is a no lock. Ferguson is a no lock. This is the Burns bone type. The Burns, it is a simple type. It is a modified type. It's the modified type. This you can see here is serration inside. When in the modified variety, this is a Burns, it's a similar type of bone holding forceps, but it has a window. It is a window, so that through the window we can give some fixation with the help of the K-web or the drills for this fixation. This is a Hay group bone holding forceps. This is a very old one. This is not used nowadays because this serration is basically it fails. This is a reduction forceps serrated. This is the most modern bone holding forceps used nowadays. Now this is another reduction forceps which is a pointed ends. It's basically for the hard bones like the patella or the lollipron. You can use this. Now patella holding clamp is basically it has both the stops because it will help in the form exhaustion of the pressure as also for further penetration inside the bone. Now these are the Matas clamp, different types of Matas clamp. There's a come in several, there is 7 types. 7 pairs of Matas clamp should be in your table before the acetabular fixation. So you can see here, this is basically it is a knobbed end. It is a knobbed end. It's straight. It may be curved. It may be dissimilar as a length. And basically these types used with the help of the screws. Screws should be attached to the both fracture ends, and the both of the screws heads are approximated with the help of this. This is the motor's 7 pair of clamps. Now these are the already asked. This is there are other types of patella holding clamp. You can see here patella holding. This is a double pronged patella holding clamp we can use, and then this is the lens bone holding clamp. You can use that. This is a bone cutting forceps. It is a handle. You can see here it is a handle. This is the bone lever and it's the cutting edge. So basically, once we cut this bone, that the cut bones it remains in the field. This is the basic difference between this bone cutting forceps and the bone gouge. Will come bone nibbler, and the bone cutting forceps. In bone nibbler, the cut bones will remain inside the plate, whereas it cannot hold the bone cut end. So use the cut bone to shape the bone grafts. The bone grafts, you can bone nibbler, you can already shown that they're just after cutting, that the cut bones remain inside its blade. So it is very sharp. You can see here. Basically, it may be single layered, it may be double layered. So this is the handle, this is the lever, and this is the cutting edge. These are the parts. Now you can see this is the double. This is one lever, this is another lever. This is a two lever. If there is a two lever, it will say the single unit of force can be doubled or tripled at the end. So this is the basic advantage of this double lever bone holding forceps. It may be straight, it may be curved. You can see, as you can see here, it may be straight, or it may be parrot beak shaped like this. Basically, these are the rongiers specifically, and these are the bone. Basically, they're the same type of instruments. Now, basically, these are used in a non-spinal operation, and these are used for the spinal operation. Basic difference is both the handles are convex. You can see here, but whereas in the spines, as it is very delicate areas we are working. So this one blade is concave, another is convex. Same design is used for the rongier also. So this is the one side is convex, another is concave. You can see, and this is the disc punch will come in the spinal instrument. The bone cutting forceps just already the repetition. This is basically the two dot Edward bone cutting or the laminectomy forceps. I will come in the spine. And this is the very is a very wise useful instrument. You can see here, very useful instrument is it is the mastoid self-returning retractor. If it basically is used for the surface, it is not come in the deeper area. For the deeper area will come. There are several self-returning retractor will come for the spine instrument. Now basically there is a punch. As you can see here, the Hayjack punch or the basically the punch and another name is the Rongier. The Hayjack punch or the Rongier is a see the up bite, this upper bite. This is either up cutting or the down cutting. These are both up cutting. This is cutting the upper part. It is a Carrison. This is a Carrison and this is the Hayjack punch. Carrison is as a longer and slender blade. This is the handle. This is the lever and the blade. And see, you can see here the same design. Is one side is convex, another side is concave. This is basically the Rongier. The Kunsa diamond or diamond tipped awl. This is for making the entry point of the interlocking nail. This is it may be with slot or without slot. Sometimes a slot will be there. So through the slot we can easily pass the guide wire after making it the slot, and it is confirmed by the C arm. So it may be slotted or non-slotted. It may be straight or it may be curved. So this is a diamond pointed awl for making the entry point of the intermedullary nail. Now, so these are the intramedullary reamer. You can see here, these are the intramedullary reamer for the intramedullary nail, non-lock nail or Kunsan nail. And basically these are the intramedullary reamer, hand reamer for the interlocking nail. What is the basic difference? Basic see, this end is very sharp. This is the cutting end. It is cutting the end cutting. It is end cutting reamer, whereas this end is blunt. Basically, it has a flange. This a flange is there, so it is basically side cutting. It is an end cutting reamer. It is a side cutting reamer. Now, giggly saw. It has a serrated wire and two hooks. It is a flexible wire saw used to cut the bones, mainly during the amputation. It has the advantage of making the bone ends bevel by changing the angle of cutting. The bone file. It has a handle and serrated blade used to smoothen the rough, cut, and fractured bone ends. Generally, if the amputation, suppose is the below knee amputation, so the anterior and the lateral edge of the amputated bone, it should be very much should be kept blunt by using this instrument. Otherwise, that will cause irritation under the skin, and that will cause rupture of the skin. Now, especially used for the patella preparation in the TKR. So, in the patella preparation during the total knee replacements, after cutting the osteophytes, the cut areas should be smoothened with the help of this. So this is the special use. Now this is a wire bender. You can see here. This is the wire bender come plier. You can see here. These small the holes are basically there for the K wires or the SS wires can be introduced, and they can be twisted with this, or K wires can be introduced to this, and that can be used for bending of the K wire. Now these are the cut. This area will used for the cutting of the K wires. There are special instruments we used for the cutting of the K wires. These are special wire cutters. Whereas there's a jumbo pliers. These are jumbo pliers with the cutting system. This is the wire cutter. Now this is the jumbo cutter. This is only the jumbo cutter. This is for the cutting the Steinman pins, 6.5 millimeter any type of pin. Now these are the bending irons. Basically, this is used for bending the K wire bending. Now hammer. Now hammer may be completely metallic, or maybe it may be one side is a bakelite type. This is a both side bakelite, or is one side bakelite, one side metal, or it may be heavy duty, or maybe small type of hammer. Now these are the sliding hammer. This is sometimes it is called what do you mean by the end blow? Just after the blow, once if the energy is finished, that is the end blows. Basically, it is used during the introduction of the prosthesis inside the medullary canal. In that is the hemiarthroplasty, the osteomal prosthesis, or uncemented the hemiprosthesis. Now this is the T handle this is the T handle or the butterfly T handle. This is inside the hollow core. We can use used with by just manually rotating with we can introduce just after drilling. We can introduce the skeletal traction pin like the Steinman pin or the Denham pin by using this. Or this is a T handle, or by the sun screw. Just after pre-drilling, we can introduce the sun screw with this. This is the specific use. This another is the butterfly T handle. It has no lock. The T handle is a lock, whereas the butterfly T handle doesn't have a lock system. Just this flanges used for tightening. The manual tightening is sufficient, and that can be used for introduction of the very slender wire like the K wire. This is orthopedic hand drill. There are the different types of drill you can see here. This is basically the closed gear drill. This is the open gear drill, and this is the micro bone drill. This is the closed gear drill. This is the ancient variety with this lock system. Basically, closed gear drill. It is a disadvantage if it becomes a mechanical problem. It has to be very difficult to become repair because it has to send for the manufacturer. Otherwise, this open gear is very easy. This is where if there is any loosening of the screw, you can easily tighten the screw and you can again use it. And Jacob's chuck can be applied. Jacob's chuck can be easily attached with this. This is open gear advantage of the open gear variety. Now this is a micro bone drill. This can be used for the using introduction of very slender wire like K wire like that. Power drill, it can be wired or the cordless. It has a chuck to tighten the drill bit. It can be used with the battery operated, or with the help of the electrical operated. This is the electrical operated, commonly known as a man-man's drill, whereas there are different battery operated drills. Now, drill bits, how to remove. This is most important. These are drill bits. There are different types of drill bits. Drill bits are the specific type of drill bits used for the specific type of screw insertion. This is asked for the 3.5 type of screw insertion. So, which type of which caliber drill bit should be used? So, this is usually asked. So, it should be at 3.5 should be 2.7. For the 4.5 should be 3.2. There are different types of drill bit. You can easily see. Now, what are what is structure of the drill bit? You can see it is a pointed ends with this is the cutting edge. So sometimes it is used asked in the exam. So which part of the drill bit is used for cutting? The students tells these are the area. No, this is the only the tip. See the tip is this has a rake angle. This is the rake angle. This is the rake angle. You can see here. Normally this cutting end usually meets at 90 degree. If it is much more pointed, it should not be good, because if it is much more point, that causes increased heat production. This should be at least 90 degree. That is a rake angle. This is known as a rake angle. Should be 90 degree. And these are it is a helix. This is the flutes, helical flutes. Normally the helical flute should be at 30 degree with the horizontal. See, this is 30 degree with the horizontal. What is the purpose of these helical flutes? These flutes are basically they can remove the bone debris it cuts. So how it is possible? So how can it be removed? So after complete drilling, that should be removed by rotating in same direction. This is the answer. We have to rotate it in the same direction, so that if we rotate in the same direction, the bone debris which cuts, that basically that is removed through these helical flutes. This is the only way to remove this boil. Otherwise, if it is accommodated inside the cut holes, that will cause excessive pressure during the actual screw insertion. So it increases pressure, and that causes heat production. Ultimately, that reduces the screw ends. Now, this is the drill slip. You can use that drill slip if you use in a MIPO technique. So if without opening, we can use this drill slip. So it can protect the neurovascular structures. Now, there are other targeting devices like this. This is a pointed drill guide. You can see the pointed drill guide. If you pass it, on the other side of the bone, so where it is intended to be drilled upon. So that we have to pass it in the other side of the bone. Is checked in the C-arm. Then only you will drill through this area. So this is a pointed drill guide. These are the specific type of drill guide. Now another type of drill guide you can see here. These are the DCP drill guide, and this is basically the AO type of drill guide. So this is the DCP drill guide. You can see here. So there are basically the either this is the drill guide. There is no telescopic ends, but here this is a telescopic tip. If we press it, this part of this part of the metal will go inside. So if we place this, if we place it inside this plate hole, that will cause a central drilling. But if we don't press it, so this type of drill, that will cause eccentric drilling. So if we suppose in this case, suppose this is the bone, so we have to displace the bone towards the side. So how can it be done? So we have to first we have to fix the bone and the plate with the help of the drill slip, like this, with a make a drill, and with the drill slip is passed halfway to this, then drag it, and then we have to put it one screw like this. One screw is in a central manner. In this type of variety, in this type of drill slip, if we push it, that will cause a central drilling. Now these are on the other side, we have to this the eccentric drilling, so that the bone is compressed at the fracture side. So how it can be done? So in that case, this type of drill should not be pushed enough. So the telescopic the tube should be outside this hole, so that will cause eccentric drilling. Or this type of drill guide is a loaded drill guide. How will you identify the loaded drill guide? There is a small the arrow is there. See, this is small arrow. The arrow should be away from the fracture site. If the arrow should be away from the fracture site, that will cause that. See, the arrow should be away from the fracture site, and that will cause eccentric drilling. It is eccentric drilling that will push the bones towards the fracture site. That will cause compression at the fracture site. After the interfragmentary compression can be done by the screw, interfragmentary screw. So this is the technique. Another is the bone tap. So what is the purpose of the bone tap? Once we drill it, once we drill the bones, so we can provide the compression force as well as the shearing force. So if the shearing force is very huge, that is detriment, that will cause temperature, that will reduce the screw purchase power. So if we cut the screw heads, screw the threads before actual insertion of the screw by this bone tap, so there is less amount of shearing force is required for screw to insertion. So basically threads is cut exactly with the help of this tap. This instrument, this is a tap, and with this a tap slip. And see, there is some small channel is there, small channel, so that the small bones which is usually removed from this way, that can be easily taken out. So it will go out through this channel. So for this purpose, for during introduction, we have to rotate the tap 2 times completely, then half times, just reverse manner. 2 times completely and half times reverse manner. So in this way, the bone debris will come out through this channel. So this is the way of insertion of the tap. So if we remove the tap, we have to just reverse the tap. So if we reverse the tap, so whole of the other types of most of the bone debris will accumulate it inside these bone channels. And that will come out. So this is the way technique usually asked. The screw depth. Basically, it is used for exactly measuring the exact depth of the screw. I'm not going into detail. There are several types of screwdriver. It has this wooden or the metallic handle attached with the shaft and the hexagonal star-shaped tip to attach the screws. You can see here, and can come with a holding slip so that the screw doesn't slip. And it is a holding. Basically, if it's a MIPO technique, once we are using the MIPO technique and or the very minimal invasive surgery, you can use this slip, the screwdriver with the holding slip. And then what is this type of screwdriver? Basically, it is a torque limiting screwdriver. Why it is important? Because torque limitation is most important, specifically during these the locking screws. Because just after completely insertion of the screw, if we try to make it further tighten, that will cause further rotation of the head in spite of further going inside the screw. That will lead to damage of the threads. So in that case, we have to limit the torque just after full insertion of the screw with the help of this torque limiting screwdriver. Now, what are the different types of screwdriver? This type of screwdriver is known as the Burns self-holding screwdriver. Whereas this type of the screwdriver is a cordon screwdriver, which is used in very depth, just for used for fixing the cup of the acetabulum in case of total hip replacement. Now, a screwdriver can also be available with the help of the T handle. So this is for better providing the torque on this on screw heads. And then there are several other screwdriver is also available. This is star-shaped screwdriver or Phillips for the Phillips head screw. This is a counter sunk. You can see this counter sunk of the T handle. When the screws are inserted at an inclined angle, not at a right angle, it is an inclined angle. So in that, so one part of the screw head first touches the cortex, and if we further tighten it, that will increases the pressure inside the cortex. That will lead to microfracture. So in that case, we have to use this counter sunk before actual insertion of the screws, so that will make a small indentation of the cortex, so that after full insertion, that will cause complete contact of the screw head. So this is for prevention of the micro trauma when one side of the screw head touches the cortex earlier in an inclined manner. Bone file function is already discussed. Now this is the instrument where the drill slip and the tap slip is used in a same instrument. Now what is this purpose of this? You can see here the triple drill guide. Basically, this is used for the tension band wearing in a olecranon fracture, because both the two K-wires should be placed very parallel, which is a dead parallel in manner. So in that case, if you use this instrument, we can introduce the K-wire in a dead parallel manner. Now there are different plate benders There's a different caliber plate bender. You can see here. You can that is always used in pairs. This is the plate bender ruler type, and this is the bending press. This is a plate bender ruler type. It can be used heavy for heavy duty plates. Now, can the LCP, the locking plate can be bent? Yes, that can be built only with this reconstruction plate bender. Is should be used for the locking plate, because see, this is a long slot. If there's a long slot that will hold the other holes, only this can bend only single hole at the middle. So because pre-bending at the middle of the plate may be required for fixation of the transverse fracture in the diaphyseal area. So that can be used with this LCP. Now this is the reconstruction plate. So reconstruction plate can be bent. What is the basic difference of reconstruction plate from the other plate? Because the reconstruction plate can be bent in the same axis. This is a Z axis, in the same axis, the transverse axis of the plate, and that can be done with the help of this instrument, basically for the acetabular fracture. Now there are different types of bone punch. There are different shapes of the bone punch. You can see here that can be used. Not going into detail. This is the SS wire passer. This is the SS wire passer that can be used for the passing for within single or the multiple SS wire. Suppose there is a periprosthetic fracture, or there is some long oblique fracture. For the before inserting the nails, we can use this type of fixation. Now wire twister. Now this is the wire twister. You can see here. If suppose the wire is available in for your tension wiring is very thin enough. So how will you do? Suppose which type of wire it is used normally for the tension band wiring of the patella or the olecranon. Suppose sometimes it should be at least 16 or 18 type of gauge. How to know the gauge? I will come. What is gauge? How to know the gauge? I will come. Now if it's a single SS wire is available in your table, and this is very slender enough. Suppose it is a 20 or 22. So this is not enough to hold the pressure. So in that case, both the two rows of the 20 type of wire can be used along with this instrument to make it like a braided manner with this instrument. This is a wire twister. This is the wire twister. This is a gig saw introducer, and basically after completion, after placement of the tension band wiring, this type of instrument is used for tightening of the SS wire. These are all instruments are already discussed. Now this is the spreader straight curve blade. As you can see here, this is the plaster cutting instrument. Now can anybody tell this is a plaster spreader? So how do I identify the plaster spreader, and how it is different from laminar spreader? Laminar spreader and the plaster spreader. So basically this is already same, almost the same looking, same structure. Now if we make it, widen it, if we open the blade, that is open the handle, the blade should be closed. Now basically it is used for removing the plaster. During the removal of the plaster, once we cut the plaster with the help of this plaster saw or the manual plaster saw or the electric cutter, we have to widen the cut area. We have to separate the cut part of the plaster with the help of this plaster spreader. Now these are the plaster cutting scissor. Is one end is blunt and that is tip is sharp. So this blunt end should be towards the skin, so that there will be no harm to the skin. Now these are the different gauges. You can see here different gauges: drill and saw gauge. You can see this is a drill, then saw gauge. You can see, and these are the intermediary nail can be measured to this. This is the gauge, which is, and these are the Smith Nephew's gauge. Basically, it's used for measuring the femoral head. Now this is the specifically gauge which is used for measuring the SS wire. What is the gauge actually? This is basically, it is a unit. How the gauge is measured? See the 20 gauge. 20 gauge means 16 gauge, and between the 16 and 20 gauge. 20 gauge means slender. So as the number of gauges increasing, it becomes slender. Number of gauges reducing, means it is wider. How do you know that? So how it is happening? That means at least a single measuring. So smaller the gauge, number wide the barrel. Basically, it comes from this barrel of the gun. Actually, suppose this is the gun and this is the barrel. Actually, barrel of the gun, and this is a specific measurable. The balls gauge can be accommodated inside. So if it's a 1 inch, if it's a 18 type, such type of SS wire can be accommodated in a 1 1 inch, 1 square inch area, that indicates the 18 gauge. Suppose it is a 20 number wires can be accommodated in a 1 square inch area, it is a 20 gauge. So if the number of wires, much more number of wire is accommodated in a 1 square inch area, that means that is the case. So see, this is the work. So I think this I will this is a completion of this general instrument. Can I start the special instrument, or can interact with the audience? Can I interact the audience, so we can
Yeah,
finish?
I think probably we should take questions now because it's already 40 minutes.
So
So
I think I should stop and I can
maybe
take
we
the
should do that in a different session, okay?
okay.
Because otherwise there will be difficult for people to
Fine,
take in
fine.
that much at one go.
So please, so I am beloved to give the answers of my beloved
Sure.
students.
Yeah.
So if there
So,
is any questions.
DNBs, sir, I have one question in the chat box, that use of serration at tip of guide wire. What is the use of that serration at the tip of guide wire?
So guide wires, basically, suppose there are different purpose you can use in the guide wire, like the before placement of uh, the, the fracture neck of femur in case of cannulated cancellous screws. So guide wire for the actual placement, actual exact placement of the specific screws. So we have to introduce the guide wire with the thread portion, because thread portion will engage in the sub control ports. So that will not deflect enough. That should not cross the area, or there should not be should not come out before actual placement of the exact length of the screw. So this thread will help in exact engagement of the tip of the guide wire in an exact subcondylar area.
So, sir, Amit, you can ask directly. He has written one more question, that, uh, sir, he want to know the sequence of putting the screw in the plate, although that is maybe discussed in the implant. But
Okay.
if you can, yeah.
So this is a very, very good question. So suppose there is some oblique. Just I've shown it. This maybe say transverse fracture. It may be oblique fracture. If it is a transverse fracture, it's easy. So in that case, we have to start the fixation of the screw in the very near cortex, near screw. Okay. So at least 1 centimeter area should be left from the fracture area. Basically, we have to select the screw, the plate, basically depending on the length of the fracture site. If it is a transverse fracture, the length of the plate should be at least 8 to 10 times. If it is oblique or comminuted fracture, it should be at least 3 times of the fracture zone. So after selection of the plate, we have to reduce the fracture. We can temporarily fix with the K-wire. Then we have to place the plate on the bones. We have to start fixation of the screw from the near areas. So at least 1 centimeter area should be left from the fracture areas. So first come on the if it is transverse fracture, there's nothing. So you can come in any side. We have to fix first on the in one side. We have to make a central hole, central drill, central. Then we have to tap it and make a screw, but should not tighten it. I would go on the other side in a transverse fracture. We'll make a eccentric hole, and then we have to make the tap, and we have to make the use the screw, proper size of screw. So first drill, then tap, then we have to first after drilling we have to use uh, the depth gauge, then tap it. Screw, depth gauge, tap. Then first we have to tighten uh, the the central screw, that is which is used in the center. For the next we have to go on other side for the eccentric screw. This is the sequence for the transverse fracture. But if it is a oblique fracture, one that means the bones with one side make a acute angle and another side will make a obtuse angle. So in that case, we have to fix the screw first on the bone fragment, which will make a obtuse angle, and then we have to make the eccentric placement of the screw, which on the fracture side, which is make a acute angle. Because so once we in the acute angle, we make a eccentric, and that will cause sliding of the bones under the plate. That the plate on the other side of the fracture side, that will prevent this overriding. But if we make the opposite one, first screw on the central screw on the acute angle, and the eccentric screw on the obtuse angle. That will cause during this tightening that it was overriding of the fracture fragment, and it was lost reduction. So if it is a transverse fracture, nothing matter. We have to come on side. We have to make a central fixation, and other side is the eccentric fixation. And they always there is some drill, then depth gauge, then tap, then we have to fix it. We have to tighten it. If it is a oblique fracture with the acute angle and obtuse angle, then we have to fix the screw first on the obtuse angle and the eccentric side, eccentric placement of the screw on the acute angle. So this is the sequence.
Sir, Gautam want to know.
First of all, then other screws should be peripheral screws should be used.
Okay. Sir, one question from Gautam. He want to know why measure should be done before the tap.
Yeah, very good question, because the measuring gauge, during measuring gauge, if you after making the tap, what is the purpose of the tap? The tap actually they specifically cuts the screw threads, so that the shearing force will become minimum, so less amount of bone temperature formation, and that will cause increases the purchase power. So if we introduce the tap, the depth gauge after the tap, so that will break the screw threads, and that will increases the bone debris collection inside the holes, and during the insertion of the screws, that will again it increases the shearing force and increases the temperature. So that is always tap should be used later on, after the use of the first drill, then the depth gauge, then the tap.
Okay,
So
sir.
the newer implants have now you're going back to self-tapping screws.
Yeah.
So a lot of these we don't tap anymore.
Exactly.
So I think, but if you are using a tap, it's good to measure before you use the tap. The second thing is, Amit, was that your question, or were you asking about locking screws as well?
Amit? I think
About
it's
sequence.
Amit? I think he's not able to say. Yeah. We have some problem with his network. Okay, sir.
So
And
the other thing is about when you're using conventional screws and locking screws, you would always put the conventional screws first and then the locking screws, okay, on one side of the fracture. So once you put the locking screws, you don't put in conventional screws on the same side of the plate, okay, by and large. I mean, there may be some exceptions in certain situations where sort of technique, and the correct technique would be to first put in the conventional screw and then put the locking screws after that. Similarly, if you're lagging, you first lag, then you put the locking screws, okay?
And sir, one more thing, in traditional teaching, after going inside, through when we are tapping, sir, we are going about 2 to 3 times inside, then should come once outside. Yes, sir. So when we are using the self-tapping screw, sir, in that case also we have to do the same?
No. That's not necessary, okay? Because here, when you're tapping, the reason you want to do this is that as you make your taps, it's causing some debris which you want to take out, so that you have a nice clean tap. When you're doing the screws, it just goes through. So take it out and put it back every time, it will get loose. Okay.
Yes.
So no questions about the instruments.
Yeah.
I'm sure there are a lot of
Sumit?
questions there.
Yeah. I think, sir, I want to know that when we are like, for the Omen retractor, it is also known as bone lever. So which answer is more acceptable during the examination, sir?
See, this is a bone lever. This is special. You
Omen
can
is a bone lever.
Yeah, that
specialized bone lever, which is popularly known as a
Not
Oman.
called it.
okay. So, sir, Amit has one more question, sir.
Yeah.
About AO and machine screw difference, and what is a wood screw?
Okay.
That
Wood
is a
this is a very,
helpful
very
information.
basic question. Wood screw basically it is almost like a similar to cancellous. So what is the basic difference between the cortical screw and the cancel? We have to understand. The cortical screw basically the thread that's a core there is a inside there is a core diameter. So there is inside the core, and on the core there are the threads are coming out. So there are core diameter and the thread diameter. So if the core diameter is very small and the thread diameter is much more, so that this type of screws are required for purchasing in bones which has a less power purchase capability, like the cancellous bone. So in cancellous bone, we have to choose the screw where the core diameter is very less, but the thread diameter is much more, so that the much more bones can be engaged to the thread. Okay, basically this is the cancellous screw, which is or whose prototype is the wood screw. Okay, basically it doesn't require the tapping. It causes it makes its pathway with just compression of the bones on the, the surrounding bones. It just make its pathway. Just we have to drill it, and we have to just once we introduce it, it increases. It makes its thread by compression of the surrounding bone. It is like a thread. So it may during insertion it causes a compression. So after full insertion, that will cause a tension inside its axis, so that the whole bone is becomes compressed with each other. And because of the larger thread, that it has a much more increasingly purchased inside the bones, which has power is less. Structurally, it is weak, like the cancellous bone. Whereas in the cortical bone, it doesn't require much more the larger thread, so it requires strength. So in the core diameter, basically, it denotes the strength of the screw, because of the bending stiffness is basically it requires it is a cubic power of this core diameter, cubic power of the core diameter. So if the core diameter is much more, in case of cortical screw, and thread diameter is less, then cortical bone it requires strength. It doesn't require much more purchasability. Okay, so in that case, cortical bone, the core diameter is much more, whereas the thread diameter is less. So if we make the percentage, the core is to thread diameter is much more in case of cancellous bone, cancellous screw, root screw. This is the modified root screw. Whereas cortical screw, there's a core diameter is to thread diameter is less, relatively less. Okay.
Sir, two very common instrument which is usually asked in this exam is one is a hand drill and another one is crutchfield tong. For that one, sir, what all question which is difficult one, please discuss.
Crutchfield tongue is not actually implant. That actually
Yeah.
it is not the instrument, it's the implant.
It's not an
So that is
instrument.
I'm okay.
Yes.
Actually, the Crutchfield tongue actually basically it is used for the cervical spinal injury. So in cervical spinal injury, so what is the protocol? In cervical spinal injury, which is a acute cervical spinal injury, first we have to make it the medical treatment. There are some if we come in within 6 hours, you have to there is a role of methyl prednisolone. Have to make the life support, and if the patient is absolutely normal and there is no neurodeficit, then but there is significant displacement, there is significant at least more than 25% displacement of the body. So in that case, we have to make the position, that is make it stable, otherwise that may cause further displacement that can lead to neurodeficit. So in that case, that is the role of traction. So traction, that may be either a halter traction, or we can give a definitive traction with the help of the Crutchfield. So in Crutchfield traction, the one line is drawn from above, that is from the mastoid to mastoid, and the line is drawn that is from front. There is a sagittal suture, and there is a Crutchfield tongue is there, and we can widen it so the white in wider area, which can touches the head. I can directly drill it inside it, and the drill bits are beaded. So as the drill bits are beaded, so it will not purchase the inner cortex of the skull. So only the outer cortex is usually cut, and so after that we just put the prongs of this Crutchfield tongue inside it, tighten it, and then we have to give the traction. And the traction depends on the number of the cervical vertebrae involved. Actually, it is a 5, 6, 8, 10, 12, 14, 16, like this. It is a minimal weight should be 5 pound. That is a 5, 6, 8, 10, 12, 15, and 18. This is the minimal weight should be hanged. And if there is no neurodeficit, we can make it double. after 4 hours, if there is no neurodeficit, no clinical is stable. And some school usually tell the first start with the maximum dose. If there is no problem at all after 4 hours, we can reduce it and maintain it. So first, there are two schools. One school is give a minimum dose, see whether neurodeficit is coming or not. If no neurodeficit come, then you have to go to say it is a maximum dose. So if it is C1, we have to give 5 pound. If it is C2, it is 6 pound. If it is C3 affected, it is 8 pound, like this. 5, 6, 8, 10, 12, 15, and 18. C7, it is 18. Maximum weight is 36. So you can give the 36 pound, and after 4 hours, we can again examine the patient clinically as also neurologically. If there is no neurodeficit, we have to do the radiograph. If the radiograph fracture is stable, then we can reduce the weight to the maintenance dose. So this is the actual treatment of the touch filter.
Dr. Gautam want to know the use of giggly saw in recent era.
Use of giggly saw
in recent era. That yeah.
In recent, yeah, giggly saw is usually used. There are two situations is commonly used. First is a very common operations. This is the amputation, and there is a very specialized operation, that is trochanteric flip osteotomy. Trochanteric flip osteotomy during the total hip replacement. These are the two areas where we can we are very scared about to use the power saw. Why? Because the power saw generates much more pressure, much more temperature that will cause harm to the area. So in that case, suppose it's amputation. So it is very easy to pass the Giggles wire saw under the bones, and we can cut it. And after the cutting, we can easily use this. It is a low energy cutting. So the less amount of temperature will be generated, and that increases the longevity of the amputation area, amputation ends. If there's increased temperature, that will cause much more death of the tissue death, and that may lead to sequestrum formation. At the same time, during the trochanteric osteotomy, suppose there is some total hip replacements, or during the acetabular fracture, suppose there is a fracture in the acetabulum during the Cocker-Langenberg approach, where we want to fix the plate on the posterior superior aspect of the acetabulum. In that case, trochanteric osteotomy can be done by passing the giggly saw just by the base of the trochanteric tip under the abductors. We can make a very low energy osteotomy of the trochanter.
So one question.
There are a couple of areas where in practice the Jiggly saw is still used, and one of them is when you're doing a Salter's osteotomy in a child. Yeah. Okay. A lot of people don't do osteotomy for THR anymore, so the Chanley method of doing the osteotomy for the trochanter used the Jiggly saw, but not many people are using that anymore. But for Salter's osteotomy and a few other things in now the corticotomy for Ilizarov fixation is also described with the Jiggly saw, so that you have a very low energy corticotomy. Okay, so those are the areas where you could use it, but practically nowadays the use is fairly limited. Okay.
Sir, Gautam want to know about difference between bolt and screw.
Yeah, basically the screws that provide the pressure. There are two types of pressure is provided by the screw. One is compression type of, another is shearing type. And that is why they are specialized type of core diameter and the thread diameter. But in the bolt, just it is a holding power. It doesn't have any compression or any shearing force. That is the basic difference between the bolt and the screw. In the bolt, there are the core diameter is very high. Core diameter is huge than the thread diameter. Thread is just for holding, just make it to keep its place, keep it in place, just for the holding purpose, just for holding. That is why it requires strength, doesn't require any compression type. So when the compression is required for the bones fixation, so screws are there. But the bolts, it doesn't require any compression. It just has been bolt, only the placement of the screw is required, and it requires strength because it can bear the weight. The area between the most distal screw and the proximal, which is the working length of the nail, which actually bears the weight from the weight is passing from proximal screw to distal screw. So that is why the core diameter is huge and the thread diameter is very less. It is it is exceeds the core diameter just for holding purpose. That is why it is known as bolt.
So I think the difference when you talk about conventional screws and bolts, I think when you're using locking screws, things change a bit. But with conventional screws, the idea is that it has to be tightened against the surface so that you get friction between the plate and the bone. While when you're using a bolt, the idea is that you hold the two cortices, but you don't tighten the screw on the bone. Okay, so when you're doing interlocking for your nails, you are not supposed to really try to tighten that bolt onto the bone. Okay, you're supposed to cross both cortices and just have it gently tight on this side, not try to tighten it too much. And very often when people try to tighten it, then it becomes loose because the very reason that the core diameter, the threads are very small, and it's the core diameter that is really holding the cortices. Okay, so you're not expected to tighten the bolts when you're using them as opposed to the screws. Okay. Okay, I think we should call it a day if there's no other questions. Thanks, Ananda, again for a great session. There was so much information there. It's difficult to cover such a large amount of things in one talk, but you managed to cover a lot of it.
Thank you.
And I think some of this will be very useful reference for the students for their exams, and not just exams, for their knowledge as well, because a lot of information there which I'm sure they, with the recordings, they can go over, and it's impossible, probably not possible for them to remember in one go. Okay, thank you very much, and I think we should call it a day. And thank you, Ashok and Janki, for your help as usual.
Thank you, sir. Thank you all. Thank you all.
Okay.
Welcome.
Okay, thanks very much.
Thank you so much.
Okay. Okay.